I want to spend a little bit of time talking about the prevalence of sexual dysfunction, some definitions or types of sexual dysfunction, how we might evaluate those problems, and then most of the time on the treatment options. And this is a common problem in general, especially as the population ages, and it intersects like a Venn diagram with Parkinson's disease. So these are not unique problems to patients with Parkinson's, but Parkinson's disease has some direct and challenging implications for the management of sexual dysfunction. So in neurology and psychology and psychiatry, there was a running debate whether this was a psychological problem or a physiologic problem, right? And I too wanted to be a neurologist. I just went to the other brain, right? So it's partially true. I did have some interest in neurology, but I couldn't get the pathways right. And it's really complicated. And once Viagra or sildenafil came on the market, it didn't matter that much whether it was psychological or physiologic, but we learned it's mostly physiologic. We learned more about how sexual function occurs, and usually it's because we're studying the disease states. Spinal cord injury gave us a lot of insight into how sexual function happens in the abnormal, and then that's the normal state. And we've started to view sexual dysfunction as less of a psychological or psychiatric problem. It's still part of the psychiatric manual that lets us give a diagnosis, and it has a significant impact on someone's well-being. And in young patients, we'll talk about performance anxiety, where they've had trouble obtaining an erection, which is a particular part of sexual dysfunction. And then they have anxiety and nervousness about their performance next time, and that releases the antidote for erections. All the stress hormones are used to reverse erections. So it's an interplay of physiologic and psychological factors. Further, there's normal variation. There's normal variation among people. There's normal variation in the same person over time, aging, circumstances. So one thing you learn in neurology is everyone is normal, right? There is no behavior that cannot be included in the spectrum of normal human behavior. And it's complicated and multifaceted, and Parkinson's exaggerates that. So this is the famous Cialis bathtub advertisements depicted for your viewing pleasure, right? And to me, what my limited knowledge of Parkinson's is my moderate knowledge of sexual dysfunction, this is the most unrealistic depiction of interface between a couple who are having the challenges of sexual dysfunction. And could you imagine the fall risk, the drowning risk, the head injury risk associated with trying to turn this into a romantic rendezvous? It doesn't work. So let's talk about some of the categories of sexual dysfunction. Libido, or your interest in sexual activity. So I read a pretty depressing article about human performance, and it was more talking about management and business, but after 50 it's downhill, right? Your athletic ability, your cognitive ability, and your sexual ability decline. And your interest in sexual activity may appropriately decline, or it may not. And in Parkinson's disease, there's an interface. So a lot of patients lose interest in sexual activity until they get started on their therapies. And there's a well-described, I think it's less than 5% of patients will get hypersexuality related to medical management of Parkinson's. And this can be relationship straining. Now, in a mature relationship, sexual activity is usually somewhat negotiated, somewhat scheduled, does not usually involve getting in the bathtub outside overlooking the beach. But there are many factors that impair, and that sounds awesome from an advertising. There's a little bit of story about those, what they were trying to convey in the marketing message of the Cialis bathtub. And it was, part of it was to appeal to female partners. I have discussed this with my partner, and she thinks it's crazy. She thinks I'm crazy too, by the way. But sexual activity or lack thereof can create relationship strain, just like the management and dealing with Parkinson's can. So they're intersecting, they're interfacing, and they're affecting our interest in sexual activity. And there's a lot of conflicting, distracting, and competing interests. If you're bloated because you can't have a bowel movement, or you're incontinent of urine, or you can't get out of your chair, the last thing that may cross your mind is that I want to be romantically engaged right now. If you're not interested, all the rest is very difficult to have happen. But in some circumstances, patients may be interested and they cannot have arousal. This is especially important for women. And when you look at the very limited amount of research on sexual dysfunction and Parkinson's disease, we make a distinction between a female member of a relationship who has sexual dysfunction and Parkinson's disease versus a male member of a relationship who has sexual dysfunctions and Parkinson's disease, and how those interact. And I did not come across any research in where both partners in a relationship have Parkinson's disease and sexual dysfunction, but that would be exponentially more complicated. So failure to achieve arousal has a specific impact on female sexual dysfunction. And it appears to be more prevalent in patients with Parkinson's disease. The thing we know the most about, in part because we have the only FDA approved, not only is too strong of a word, until last year, the only FDA approved treatments, and therefore there was a lot of funded research, is on erectile function. It's also fairly objectively measured. And what dysfunction is varies from person to person, but we have a consensus guidance that an erection inadequate for sexual performance that is distressing is our both clinical and research definition of erectile dysfunction. Something that people don't really like to talk about too much is ejaculatory dysfunction. And that is either too soon of an ejaculation or orgasm, or a delayed or inability to have climax. And both occur at a greater rate in patients with Parkinson's, and both increase as we age. They usually don't occur together. They're the extremes of the spectrum of the physiology of ejaculation, which is, especially for men, tied to orgasm, and which is an autonomic nervous system function. So we know that Parkinson's affects the autonomic nervous system. We know that a lot of the medicines that are used for the treatment of Parkinson's or depression impact those things, urinary function. And so it's a very common, not well understood, and with limited treatment options, disorder of sexual dysfunction. So when thinking specifically about Parkinson's, and practically speaking, we have all these parts of sexual dysfunction can be impacted. And they can be exaggerated, exacerbated by the medications that we're using. And then we haven't even considered the context of real life, of how an interpersonal relationship may or may not be impacted, and how the actual motor planning, right? When you're young, you think about sex a lot, but you don't think about the physical act of sex. Or maybe you did, I don't know. But it's almost automatic. It's not, The subtleties of it might require practice and relationship expertise, but getting it on isn't that hard, right, when you're 25. But when you're 50 or 75, even if you don't have Parkinson's disease, it becomes something you have to concentrate a little bit more on. You might have to plan, and that is much more difficult if you have motor difficulties. Okay. So I'll try to distinguish when I'm talking about erectile dysfunction, which is easier as a urologist to talk about because we have a lot more knowledge and a lot more treatment, or more global problems. But let's just talk a little bit more specifically about erectile dysfunction. The prevalence is high, and it increases as we age. So as many as 1 in 20 40-year-olds will have significant bother from erectile dysfunction. And by the age of 65, more than half of men will have at least mild to moderate. Now, it's not an inevitable consequence of aging. I have a practice that includes a lot of older patients, and one of my favorite comes in every year for his Viagra refill, and he's 97. Right? Something to aspire for. And there's pretty good data, pretty good research that says that the global sexual dysfunction and erectile dysfunction have an increased rate in patients with Parkinson's disease. What that is due to is controversial or uncertain, and whether it's really related to the neurologic aspects of Parkinson's disease has not been well studied and has not definitively linked. But since the development of Viagra, which I believe was approved in 1999, and changed the way we approached the treatment of erectile dysfunction, it doesn't matter, right? It doesn't matter if we have a treatment that is safe and effective, whether this is a neurologic problem or some other non-motor component of Parkinson's that's contributing to it. So this is a depiction from the famous Massachusetts male age study. It's self-reported difficulty with erections as we age, the severity and prevalence increases. So I want to say, and this is a little bit embarrassing, that we don't really talk about female sexual dysfunction like we should. It's half the population. We know it's very prevalent. And there is no one who's really decided that they want this to be their area of expertise as a specialty. You would think the gynecologist would be interested, but there's not been much treatment, so it's kind of frustrating for physicians. Urologists got into this because there was some hope that the female Viagra would be beneficial, and it wasn't. And the most common aspect of female sexual dysfunction is much more complicated. I'm not talking about physiologically more complicated. The physiology of an erection is amazing, if that's what you're into. But the treatment or understanding of the complex interplays of interpersonal relationship, personal well-being, and physiology are more dramatic and more subtle at the same time in female sexual dysfunction. And the most common is decreased libido, which is described as hypoactive sexual desire syndrome, which talk about taking it out from a common language to an uncommon language. And we have a treatment for that that's FDA approved. It's Velisa, or Velisi, and it is effective in improving or decreasing hypoactive sexual desire syndrome. But as I understand, I've never prescribed it, as I understand it, it requires 3 subcutaneous injections per day to slightly, but statistically significantly improve your desire. Doesn't seem like it's going to be something that's going to make as much money as Viagra did. Again, if we can turn that into a pill and it works, then I think that will be a very significant game changer. Arousal is a more important aspect of sexual dysfunction for women from a mechanical standpoint. If a woman is not aroused, and this is worse in post-menopausal, they will not have lubrication success. And this will complicate traditional penis into vagina sexual intercourse. And we have lots of treatments for that, but if you don't talk about it, you're not going to know that you should have topical estrogen replacement therapy, that there are certain over-the-counter lubricants that can really help with sexual function. And this is something that patients are not comfortable discussing, and nor are physicians. It leads to uncomfortable sexual intercourse, which then leads back to interrelationship dissatisfaction, loss of libido, hypoactive sexual desire syndrome, and it can be treated. We have tried off-label Viagra and its cousins to help with sexual dysfunction in women. It does help a little bit with lubrication dysfunction, but in the woman, the clitoris is the penile analog. So you do get clitoral improved blood flow with Viagra in a woman. And the clitoris is very important for sexual satisfaction, but it's not measurable rigidity that we can link directly to participation in sexual activity. So it's been somewhat disappointing that increased blood flow to the clitoris doesn't lead to better sex life for women. And we've also given testosterone. So I'll talk a little bit about testosterone supplementation in men, but we've also done the same thing to women. So women normally have some testosterone. There's a balance between testosterone and estrogen. As we age, those balances change, and giving women testosterone is not FDA approved, but has been associated with some improvement in desire and satisfaction with sexual relationships. All right, I like this picture. It came from a journal article, a urology journal, and it doesn't have the gut in it, right? But it links all the parts of the body, the brain, the heart, I don't know if they're talking about blood flow or soul or emotion, and the genital organs of a female, and they're all much more interdependent than the perception, real or imagined, of male sexual function. So you always, any organizer of an event should be leery of inviting urologists. My children are teenagers and they think I'm crazy, and they're right. But they talk about this stuff without a filter around me, which I think is a great thing for a parent. So causes of erectile dysfunction. So bad blood flow, especially related to male erections, neuropathy. So those two right there are diabetes. So there's some good evidence of overlap of diabetes and erectile dysfunction. We cause it in neurologic surgery all the time. The medications we prescribe can have an effect. You can be born with some abnormality that precludes normal sexual function. Depression is definitely associated with decreased sexual function, enjoyment. Illicit drugs, so medical marijuana is now going to be available. We know that recreational marijuana has a very adverse impact on sexual function, as does general tobacco. Medical conditions, there's a long list, and only some of these are reversible. And then medications. So a lot of medications have been implicated, cardiovascular medications, psychiatry medications, and in many cases they cannot be reversed. There's been, picking one class over another has only a small effect. And so prior to 1999, when we didn't have Viagra, we spent a lot of time trying to modify these things because that's all we have. So if you seek out the care of a urologist and you have concerns related to sexual function, most of our information will be gained from our history. And if we do our job well, which we don't always do, we'll be explicit and the filter will be gone. And it may take multiple visits to get all the information that we need to understand. And we may do some blood tests, including testosterone, especially if you have decreased desire. And we may go looking for other medical conditions that may impact. Now, my personal experience is the vast majority of patients that come to me have already had almost all of the general screening tests done. And if you have Parkinson's, you've definitely had all these things done, other than maybe testosterone. So I don't know if there's any golfers in the group, but I wanted to move to what our treatment options are. So to me, this is an increasing intervention severity from the least risk to the most risk. So education and counseling. So there's it's my opinion that there's a psychological component to all aspects of erectile dysfunction. Utilizing interventions based on that have had limited success, mainly because it's resource intense and it's not something that is the big focus of a lot of therapists or psychologists or psychiatrists. Couple therapists can help with this. They're usually working with something that's a more fundamental problem before intimacy in the relationship. And if those improve, that alone is enough to get intimacy more in the foreplay. This is, as far as I could tell, not been studied specifically in much detail related to the intersection of sexual dysfunction and Parkinson's disease. The utilization of testosterone supplementation is hugely controversial. Low testosterone is more prevalent in men as we age, and the symptoms that we attribute to low testosterone are also more common. But there is very limited data on a 1-to-1 ratio. So there are people that have profound symptoms that when I hear them, I think, oh, that person must have a low testosterone, and we do the blood test, and they have a normal testosterone. And then, for another reason, we may check a testosterone level and find it to be very low, and the patient has none of these symptoms. So when they converge, a low testosterone and symptoms that we would attribute to low testosterone, which are somewhat vague and sound a lot like the psychiatric symptoms that someone with Parkinson's might have, including decreased energy, decreased strength, depression, but also decreased interest in sexual activity, then we consider the pros and cons of supplementation with testosterone. And in some patients this can be successful, and there's at least a few articles that say that in men with Parkinson's disease and sexual dysfunction and low testosterone, supplementation can improve many of the symptoms that we would attribute to low testosterone. The controversies are that there appears to be an increased risk of cardiovascular complications. The delivery mechanism the safest delivery mechanism is transdermal application of a gel. So if you have motor planning problems, putting that gel on is difficult. And that's not a gel that you can ask your partner, if they're a different gender, to help you with, because it's dangerous for them to be touching testosterone. So the practical side of it is difficult. In my personal experience, I have a lot of patients on testosterone supplementation, as very few of them have Parkinson's disease. Okay, anyone from Olean? So I moved back to Columbia after a 4-year tour of duty with the United States Air Force in 2004, and it took me 2 years to find the Olean Testicle Festival. I mean, it's an old slide. I've been given this some form of this talk for a long time, but it's still going strong. I just haven't been back. One time was enough. Okay. So most of the time we treat sexual dysfunction, we're treating erectile dysfunction, so that's a male with difficulty with erections, and we're going to use oral therapies. So prior to 1999, we had some medicines that did not have to go to the traditional FDA approval process and were used off-label, and they're still available. Trazodone is especially interested. It is, my perception is widely administered, usually for sleep or some depression or psychosis, and it is associated with the opposite of no erection. That's a priapism. Priapism is an undesired erection that lasts for more than 4 hours, and we see that in consultation a lot in the emergency department, and trazodone is a common cause. So I would discourage anyone from utilizing trazodone for improvement of erections. The FDA has at least 4 approved oral agents, and I use the trade names because the generic names are difficult to say, though Viagra and Cialis now have generic versions available, which can decrease the cost of taking these medications. And it's interesting to hear the discussion about apomorphine. It has been used in Europe for the treatment of erectile dysfunction for 40 years. Was not approved in the United States, in part because it has to be given subcutaneously to be effective, at least in the initial studies. I think there's an oral form available now, released for the treatment of Parkinson's, but it has a high rate of nausea. So honey, I have a headache turns into honey, I feel like oh wait, I am throwing up. So it never took off in the treatment of erectile dysfunction. But it'll be interesting to see if it gets wider traction in the treatment of Parkinson's disease, if there's an improvement in sexual function along with that. Every group that has been studied, these medications are effective. They're not a cure, and they're not 100% effective 100% of the time. But the most common causes have been studied very well, and there is up to a 90% success rate. And in patients with Parkinson's disease, there's definitely improvement over control or placebo groups. They're generally well tolerated. The folklore is that Viagra was being developed to treat high blood pressure. So one of the side effects is low blood pressure, and that can be life-threatening if combined with nitroglycerins. And it would be a particular concern in patients who are already having autonomic nerve dysfunction or hypotensive, like many patients with Parkinson's disease. And the story goes something like this. It wasn't very good at controlling the study's participants' blood pressure, and they had a relatively high rate of adverse effects that would never work for a medication treating high blood pressure, which is generally asymptomatic. So there was about 30% of patients who had mild or transient nausea, 25% of patients who had headaches, nasal congestion, blue-green vision changes. There's no way a drug like that would be utilized for the treatment of high blood pressure. But at the end of the study, none of the men wanted to give the medication back. And Pfizer, who makes this, said, "What? Why?" And someone finally said why, and then they were on to something. Right? In an individual, the side effects might be severe. I've had a couple patients who've had disabling headaches afterwards, but in a group of people, they're generally well tolerated. The different brands have different specificity to different pathways. They're all in the same class, but they have slightly different specificities, or they have different half-lives. And so finding one that works for a particular patient can require some trial and error. And the error can be relationship distressing. And I used to give samples. They're not very generous with the samples anymore, but I give samples to patients. And they would, and I'd say, well, try these and see which one works best, and we'll give you a prescription. And then I've had more than one spouse says, I don't want to be the experimental group, right? We're not trying these just to see what works. We're going to work on our relationship. So you have to be pretty open. In my personal experiences, we have a lot more success if a couple comes in to discuss what this means. There have been hearing loss and blindness ascribed to these medication classes. It's very uncommon, and it's not really clear whether they're associated or not. So the advantage of those oral medications, if you can swallow a pill, which is sometimes an if for Parkinson's disease patients, and you can negotiate an opportunity which requires more hurdles in someone with Parkinson's, but is really not much different than any aging couple, then they can be very effective. Other alternatives that are low-risk vacuum erection device. This is a cylinder that goes over the penis, pulls blood into the penis, and then a constriction band pulls that blood in. And it used to be covered by Medicare, and it cost $400. Medicare decided this was not something we were going to cover anymore, and the price went down to $40. And you can have an excuse from your urologist to go to the adult store of your choice to pick one out. A bunch of people take the prescription, very few fill it. It's mechanical, it's awkward. You have to have a very compassionate, understanding, engaged relationship for these to work well. And the motor planning, I mean, they're difficult for people without Parkinson's disease to use. They have automated ones that have a battery that, instead of a pump. But they're not for everyone, but they're worth a try because there's no medication side effects. There's no mechanical, it's irreversible. If it doesn't work, you just don't use it. So it's a reasonable thing. Getting medications into the penis to facilitate an erection can be done in one of two ways. This is the medicated urethral suppository for erections, or MUSE. So it's someone's muse. I don't know if there's any writers or poets or playwrights in the room. A little plunger puts a little suppository in your urethra. It hurts. And 70% of patients get an erection that's adequate for sexual intercourse 70% of the time. It can and does cause hypotension. So again, we're talking about a drug that someone with Parkinson's would have to have the motor dexterity to get this into their urethra and then not get hypotensive and pass out. So I'm not going to recommend it. So I've got something even worse. And that's a direct injection of the similar medications directly into the penis. And it's awesome, right? It is the most reliable erection, but it isn't worth it. and again, think of the dexterity of drawing up the medication. There is no there is no bathtub rendezvous with intracavernosal injection therapy. It's amazingly well tolerated. In a survey of urologists, this would be their go-to thing. Highly reliable, no systemic side effects, and then our party line is the needle is small and the medications don't hurt. Right. So the last thing is surgical implant of a prosthesis. I've got one right here. No, I don't personally have one. I've got one in my pocket. and this is awesome if you're the surgeon. It's a lot of fun to put in. It's mechanically beautiful. Engineering is amazing. But this little bad boy right here lives in your scrotum. And you have have to have the dexterity to pump this, right? But it's not like this. It's covered by the skin of your scrotum, and it moves fluid from this reservoir that we've implanted behind your pubic bone into these corpora that we put into your penis. And it does provide an excellent erection on demand. But there's surgery complications and the manual dexterity to do this. So this is uncommonly performed, and I personally do not have any patients that I've done this on that I know have Parkinson's disease. But it's kind of the last thing in the regimen of treatments that we're going to likely do.
A few years back, I heard it cost $25,000.
Oh yeah, all right, it looks like I'm out of time, but I got the cost. It is $25,000, you were looking ahead. So all these costs are real. And the good news is that the oral medications now with generic equivalents have gone down in price. So I look forward to questions at my opportunity at the end of this, and thank you for your attention.